Dr. Lustig, you have a chapter in your recent book called Because Pharma Was Their Teacher. Please explain what that was about.
Yeah. So let's explain why it's only half a clause. Chapter 3 in the book basically says doctors need to learn about nutrition. The chapter 4 basically says dietitians are insane. Chapter 5 says the dentists lost their way. And then finally, chapter 6 says because Big Pharma was their teacher. So it kind of goes in order. What you need to understand is that medical schools today are set up based on a report that was issued in 1910. Okay, it was called the Flexner Report. And Abraham Flexner, who was an educator, not a doctor, his brother was a doctor. Simon Flexner was actually the president of Rockefeller University at the time. He wrote this, and he wrote it at the behest of John D. Rockefeller. John D. Rockefeller underwrote the Flexner Report in 1910. Now, why did John D. Rockefeller, who was a Baptist who didn't believe in medicine, who actually believed in folk cures, want to fund a complete overhaul of the entire medical establishment? What was in it for him? And the answer is 2 words: coal tar. Coal tar. He, head of Standard Oil, okay, one of the byproducts of refining petroleum was a whole bunch of coal tar. Now, it had been shown that coal tar could be used as a therapeutic for various, especially skin conditions, but other conditions as well, and actually is one of the top 10 discoveries of the 19th century in terms of therapeutics, and is still used today for eczema and various other sundry disease processes. He wanted to get into the pharmaceutical industry. He wanted people to use coal tar. And he set up the Rockefeller Institute for Medical Research in 1901 with that in mind. And he ended up funding Abraham Flexner to do an overhaul, basically saying, doctors need to learn how to prescribe medicines. And that's what the Flexner Report said. It was about evidence-based medicine, and it was about pharma, Big Pharma, because he was getting into the field. In fact, that's how medicine basically got co-opted. Nutrition didn't even exist in the Flexner Report. It wasn't even mentioned. Not one word about nutrition in the Flexner Report, which is pretty funny considering the Flexner Report came out in 1910. The first vitamin, thiamine, was discovered in 1912, 2 years later, where we realized, oh, there's this stuff called micronutrients. Vitamins actually cure diseases like beriberi and pellagra and scurvy, etc. That didn't make the Flexner Report. And so the Flexner Report basically served as the template and the blueprint for the overhaul and the closing of numerous medical schools at the time, and basically abdicated any responsibility for nutrition to Big Pharma. And to this day, the nutrition is only part of the curriculum in 28% of medical schools in the country. And the number of contact hours that doctors learn in those 28% is a median of 19.6 contact hours. When you consider that a normal medical education is about 6,000 contact hours, the fact that nutrition, which could solve 75% of chronic disease, is given a total of 19.6 contact hours is pretty laughable. And so the concept that pharma controls the medical curriculum because they underwrite the medical curriculum, they provide 80% of the operating budget of medical schools today. So they don't want to know anything about nutrition. They want to know about how to prescribe. It's about the prescription pad and the procedure.
You just said that 80% of the operating budget of med school comes from pharma. Is that what you just said?
That's what I said.
What does that mean, the operating budget? Does that mean their money to run the schools?
Money to run the schools, yes.
And in return for that, do they have complete control over the curriculum?
Well, they have a whole lot of influence and input into the curriculum. I wouldn't say they control it, but they certainly influence it.
Dr. Harris, would you comment on, sorry, one second, on endoscopic knee surgery for arthritic knee and hip pain? Is this something that there is evidence that it's effective, or do you have any information on this?
Yeah, it's a very famous and I think a cautionary tale of how we should be practicing medicine, and in particular surgery. Unfortunately, the way surgery is practiced it's like an apprenticeship. I did that apprenticeship. I ended up operating and doing the procedures that my mentors had taught me to do without really just assuming that they worked, and without really critically looking at them, appraising them properly. And one of the most common procedures in the world, and particularly in orthopedic surgery, which is where I work, is a knee arthroscopy, or what people sometimes call keyhole surgery, where cameras and instruments are inserted through very small incisions into the knee. It became very popular in the 1970s and 80s. And sometimes with good reason, because the alternative was a bigger open procedures with big scars. And so it seemed like it was a good idea. And unfortunately, surgery, as I said, is largely based on what we call observational evidence. And so what we were doing, and what I was doing this procedure widely in the 1980s and 1990s, is that somebody would come to you with knee pain. And often if they're over 40 or over 50 years old, they will have degenerative changes in their knee. I mean, that's just a normal finding. It was hard to see on x-rays in those days, but if you do an MRI scan of anybody that age or older, you're going to see some signs of wear and tear, and often the meniscus inside the knee starts to dry out as we get older. It gets cracks in it. And so we were seeing that and thinking, wow, that must be the cause of the pain. So we'll go in there and clean it up. And so we used to sort of scrape out the knee, take out any loose or torn pieces. And then later on, we'd see the patients, and a lot of them would say they got better. So we would attribute that improvement to the procedure. And now that's not scientific, because we don't know what would have happened to that patient if we had not operated on them. And it turns out that people with degenerative knee conditions, they sometimes have pain, sometimes they don't. It goes up and down, and sometimes they'll have a bad week and a good month and a bad year. If you take that patient with a fluctuating condition and you do something to them when their pain is at its peak, you can do anything to them and their pain won't stay at the peak forever. I mean, it's going to go back to the average. And so the thing was, you had to try and operate on them before they got better on their own. So we'd operate on them pretty quick, and then we'd see them, and sometimes we'd see them a couple of weeks later and they'd say, no, my pain is still really bad. And we'd say, that's okay. Sometimes it takes surgery a while to work. And then they'd come back, another month later, and their pain would finally be better, because it was going to be anyway. So that's why we were doing so. That's why it was the #1 procedure in orthopedics, was knee arthroscopy. It wasn't until people started doing studies where they said, let's see what happens if we don't do knee arthroscopy in some people and we do it in others. And patients were randomized as to which one they got. So it was the toss of a coin. So this is a good scientific way of finding out how it works. And when we did those studies, there's now been about 15 of those studies done in the last 20 years or so. And virtually all of those studies have shown that surgery is not better than whatever the alternative was. The alternative could be physical therapy. And in a couple of cases, the alternative was placebo surgery, where small incisions were made, but no procedure was done on the inside of the knee. And the beauty of those studies is that the patients didn't know whether they actually got the real procedure or the pretend procedure. And those studies showed no difference. And it's amazing when you look at documentaries that have been made about these studies. They show, there's one with an elderly man running around playing soccer with his grandchildren and saying how happy he is with the procedure. And he had the sham procedure. He didn't actually have the real procedure. And I need to make it clear, it's not that the procedure had a strong placebo effect. It is that they would have improved anyway with an alternative treatment or even with no treatment. Now, the other interesting thing is what's happened to that procedure since then. So these studies have been out now for more than 10 years. We published in Australia, we've shown that the rates of knee arthroscopy in between 2011 and 2017 roughly halved. It's a 48% reduction. Huge reduction. In Denmark, it's fallen. In areas of Norway, it's fallen. It hasn't fallen in a lot of other countries. And in a lot of places in the US, they're still doing it just as much. And even pockets here, if I go around to my local private hospital, surgeons are doing operating lists of 10, 11, 12 knee arthroscopies on patients 60, 70, 80 years of age, which is basically just a waste of their money and my money, because I'm paying health insurance premiums and I'm paying government levies and things like that. So that's the story of knee arthroscopy. It got introduced before it got assessed. Things should be assessed before they get introduced. And it's the other way around with surgery.